to this audience. Ooh, it's like we're recording. Got it. Yeah, by way of background, I did my training as was very kindly introduced by Teresa at UCSF for pediatrics. And my first job out of residency was at a hospital in northern Ethiopia, where we were specifically charged with the task of bolstering a medical education program. But while we were there, we started trying some small changes that ended up making a big difference along a number of quality metrics. And that's what I would be presenting on today. We've been working, Alon and I have been working together on a program here at UCSF. So the way we've crafted this presentation, I'll describe kind of my experience as an example of what challenges and what experiences one might have on the ground. And I'll hand the baton to Alon, who will describe a UCSF quality improvement training program that he, Sujatha Sankaran, and I have been trying to orchestrate here at UCSF. I wanted to give you a chance, Alon. Is there anything in addition to what Teresa had mentioned that you'd like to say to introduce yourself?
No, not really. I think that was a great introduction. I'll just say that I came to this work initially because I was, I guess, struggled at times with why things didn't quite work the way that I had hoped they'd work, particularly in the global health setting, but also here at UCSF and in California. And I started to think about how does QI apply and how can we use it to help improve healthcare delivery in global health settings. So that's kind of how I came to this work in a roundabout way. That's the only thing I'd just add just there.
Thanks, Alon. Advance the slide. There we go. Well, we'll start off today just describing the problem, quality gaps in low and middle income countries. I'll describe an early success we had at this hospital in northern Ethiopia. I'll describe an Ethiopian QI training program that we piloted in that site. And then I'll hand the baton to Alon, who will discuss the UCSF Quality Improvement and Patient Safety Training Program that he's taken the helm on. We wanted to give as kind of an introduction and a quick welcome to the session. We wanted to acknowledge the experience that all of you have had in quality improvement, specifically in low and middle income countries, if you've had that experience. But if you haven't, we wanted to offer you the chance just to describe the feelings and thoughts that you have about quality improvement here in the United States. To do this, we were hoping you'd be able to use a whiteboard. Let me launch that for you. Share screen. And I'm told that if you click on the view options in your Zoom and select annotate, you'll be able to write on the whiteboard. What we're specifically interested in hearing from you is how and whether you've had experience in quality improvement in low and middle income countries. And also, what frustrations have you encountered while working on the quality improvement? You can either write free text by hand, or you can select this text feature when you're writing down. Just kind of to get the juices flowing, if that's okay. Great. Sounds good, Ruth. No assumptions about background experience, just wanted to acknowledge the diversity of experience. Sustainability, that really resonates with me. How do we create a project that doesn't just address the metric while we're there and can be vigilant personally, but what can we do to create a situation where an improvement is sustained beyond the time we're there? Oh my goodness. This sounds like a very robust program in Kenya and Uganda. We're excited to hear more from that respondent. And either what experience you've had or any challenges you've come across in quality improvement. Here we have someone saying only in the United States, implementing quality improvement in a busy safety net clinic setting. Oh boy, it sounds like someone might be working with me at the General. It sounds like a very familiar experience. Have someone responding cultural sensitivity. That is challenging, especially if this culture of, in my experience, culture of blame in particular is very challenging to get over. And also the culture of hierarchical practice can be really hard to include nursing staff and other ancillary providers. Antibiotic treatment practices for pediatric fever. Oh, huge problem. I'm hoping that you had a success there. A challenge is sustainability and identifying local champions. That really resonates with my experience too. This is really great. Thank you everybody for your time and sharing your experience. It's clear we have a diversity of experience in the audience. Please feel free as we go forward to chime in. And we're hoping that this leads to a robust discussion during the Q&A session in just a moment. Thank you. As many of you may be aware, an estimated 5 million people die each year due to poor quality healthcare in low and middle income countries. This is, at this point, a bigger problem based on modeling than access to healthcare, and it is almost as big a problem as poor public health. It's time that the world starts to discover healthcare quality and recognizing it for being as important as healthcare access. If we take disability into our accounts, the problem looks more dire still. An estimated 33 million disability adjusted life years are lost each year due to unsafe medical practice. This makes healthcare the 14th leading cause of death worldwide, on par with malaria and tuberculosis. 2/3 of these lost disability adjusted life years are happening in low and middle income countries. A recent Lancet report looked at the extent to which healthcare providers adhere to guidelines. We can see from their data that even when clear clinical guidelines, clear evidence-based guidelines are available to providers, the extent to which providers adhere to those guidelines varies tremendously. When there's variation around standard of care, it allows opportunities for patients to fall through the cracks and get hurt. And this likely is contributing to a lot of the problems we're seeing with poor quality healthcare in low and middle income countries. That's not to say that the world isn't aware of the problem. In 2015, as many of you know, the UN published its Sustainable Development Goals. Goal 3.8 reads as follows: achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. The inclusion of the word quality in this language suggests that the international community is finally taking healthcare quality as seriously as it needs to be taken. Fortunately, the world isn't starting from scratch. Since 2000, the World Health Organization has been offering technical assistance and guidelines for what they call health systems strengthening programs. A number of agencies, primarily funded through USAID, fund healthcare improvement initiatives by partnering with consulting firms and non-government organizations. The three biggest seem to be Chemonics, Management Sciences for Health, and University Research Company. These organizations consult with national ministries of health, which provide infrastructure for implementation. You can see this is a fairly top-down direction that health systems strengthening programs are operating in. And they've done an absolutely incredible job getting resources to hospitals in low and middle income countries like never before. Unfortunately, once the resources get to the hospital, there's no guarantee that the resources are actually being used by providers to benefit the vulnerable patients that are being targeted. Something needs to be done to entrain healthcare providers into this infrastructure And that's proven fiendishly challenging for a lot of these programs. I'd like to argue in this talk that this is not just an academic problem. We know that policymakers are extremely good at creating clinical guidelines that work for a given site. We know that they're good at delivering resources to the hospital, and we know that they set targets for clinical performance. But we also know that it's the clinicians who are responsible for implementing clinical guidelines, using the resources that are getting delivered, and hitting the targets that are being set. And unfortunately, between policymakers and clinicians lies a tremendous amount of local interference, site-specific problems and obstacles that get in the way of clinicians doing the best they can with the resources that they have at their disposal. Alon and I will argue in this talk that we should probably leave or support the existing system because it's not broken. It's delivering resources to providers, and we need to do everything we can to continue promoting that resource. However, there's a huge opportunity in global health to work with healthcare providers on the ground level, site by site, in a bottom-up direction to optimize the use of those resources in caring for patients. In 2010, as I mentioned, I joined the University of Gondar Hospital in northern Ethiopia. At that time, it was a lot like other African hospitals. It was the only tertiary care facility caring for about 7 million children under age 14. We saw 3,000 admissions per year, and we were responsible for training 400 medical students per year. At our disposal, we had intermittent medical supplies, very limited subspecialty services, and one of Africa's highest nurse and physician turnover rates, which really limited our institutional memory. When we arrived on the ground, we had one supervising Ethiopian pediatrician, 4 general practitioners, and no residents. And we had 21 interns. In Ethiopia, general practitioners operate at the level of kind of American interns based on their training system. And interns operate kind of like sub-interns or fourth-year medical students in the United States. In short, like other African hospitals, we were overworked and under-resourced to meet the needs of our community. Shortly after I arrived in Ethiopia, the department chairman, the one pediatrician in the department, invited me to participate in a research project. He was interested in understanding why children, non-neonatal children, were dying during their inpatient stay. We looked at this data in a lot of different ways, but by far the most actionable were these so-called statistical process control charts. On the left, we're looking at mortality occurring within the first 24 hours of admission, kind of a crude measure for the quality of our emergency medicine. On the right, we're looking at mortality occurring at any point over the course of a child's admission. These are very crude measurements compared to what we can do in the United States with risk-adjusted mortality. But this was what we could do with the data at our disposal. And they're both national benchmarks in Ethiopia set by the Ministry of Health. For those of you that haven't seen statistical process control charts, the dotted lines in the center of these two charts represent monthly mortality. And the squiggly lines at the top and the bottom of these charts represent plus and minus 3 sigma from the mean. Of course, the horizontal line in the center represents the mean mortality over the course of that data collection period. We can see pretty quickly from these charts that in any given month, we could expect around 2.2% of children to die in the first 24 hours, and that might range from 0% to around 5.5%. Overall mortality at any point during admission, we could expect about 6% to die, and that could range from around 1% to about 12%. We brought this data to our department and asked them, why do you think the data looks this way? And fairly quickly, actually, the department identified 3 major problems and 3 potential solutions. First, they said, I think I can understand why there's so much variation in this data. We don't have any standard of care, even between the supervising attendings. Why don't we work together to come up with a best practice guideline for our hospital and standardize around that? Second, they said, we don't have any institutional guideline, so it's very hard to hold our interns accountable for their performance. Why don't we laminate and post institutional guidelines on the ward so that the interns can take these laminated guidelines to the bedside when they're confronted with a pediatric emergency, kind of akin to what our interns get in the United States in the form of a code card. And third, they said, our interns are very poorly prepared for pediatric emergencies. Why don't we offer them a simulation-based training program using mannequins we already have access to so that they can rehearse emergency situations in a safe environment. As chance would have it, we were able to implement all three of these interventions at about the same time and immediately saw a dramatic decrease in our mortality. In the first 24-hour, mortality dropped from 2.2% to 1.2%. We also saw a 45% reduction in overall mortality. But just as important as the decrease in mortality, we also saw a tremendous drop in variation around that new mortality rate. This was aligned with the design of our intervention. We wanted to improve practice, pushing the mortality down, and we wanted to standardize practice, decreasing variation around that new target. We were very excited about this, but I have to be very transparent and say I wasn't super hopeful, and many of you who have experienced problems with sustainability of results will probably resonate with that comment. Here we had 4 months of data, which is by no means definitive, but nevertheless, we thought we had reason for celebration. It turns out there was enough energy behind this initial promising data that the department took it upon themselves to set up a morbidity and mortality conference program. Through the M&M conferences, they continued to identify problems in the hospital and develop solutions to those problems. First, they found that there was a lot of confusion over patient transfers. Patients were initially triaged in an outpatient department in one corner of the hospital. But our inpatient ward was available at the opposite corner of the hospital, almost 2 football fields away, and patients were getting lost. So they asked the interns stabilizing the patient in triage to escort the families to the ward at the time of admission, decreasing confusion. Second, they said our outpatient department, where children are initially presenting, is very far from any resuscitation facilities. So using funds already available in the department, they constructed a ramshackle resuscitation room adjacent to OPD that had the resuscitation supplies to stabilize patients before admission. Third, they said, we have no advanced critical care for children. So they repurposed an unused physical therapy training space into a 3-bed intensive care unit, I would put in quotes. Essentially, it had a dedicated oxygen cylinder for each bed and a dedicated pulse oximeter for each bed so that we could get better control over a child's respiratory status. And lastly, they identified a problem around the admission process for dehydrated children. So drawing from data from India, they repurposed an unused pharmacy closet into a 2-bed outpatient rehydration unit where dehydrated children could be fluid resuscitated, stabilized, and then sent home to their home community for recuperation rather than needing an admission. This bypassed the problem altogether and seemed to work. Far from becoming complacent, they really locked down the new mortality rate and really minimized variation around that mortality. After continuing to follow the data over several months, we saw a final 32% reduction in mortality in the first 24 hours and 48% reduction in mortality throughout admission. At this point, Dr. Moretti and I scratched our heads a little and asked, wait, what just happened? Bear in mind, this was in 2010 when quality improvement was kind of a little bit of a new concept in a lot of the global health space. What we found was we decreased mortality and standardized care along international guidelines. The improvement occurred with no change in existing resources and no financial incentives to providers. Data collection was incorporated into routine care, and data was being used to drive management decisions. And the department had developed a self-sustaining culture of improvement that allowed them to continue identifying targets and develop solutions long after the expatriates left the site. We know that this is the power of quality improvement, and those of you that have worked in this field know how powerful this can be. It's been demonstrated to work in sites as varied as the United States and Malawi. Core to this program is the Plan, Do, Study, Act cycle, where interdisciplinary teams iteratively develop plans, implement, study for effect, and revise the plan until a target is reached. We decided to institutionalize quality improvement at Unger University Hospital. We wanted to develop a QI program specific for our site, deliver it to our resident trainees and to our nursing staff, help each QI team accomplish one PDSA cycle per team, and then evaluate the impact. Dr. Moretti and I developed the first battery of training modules and delivered them to the residents in 2011. We got feedback from the residents that was extremely helpful in orchestrating another batch of training modules that we offered as supplementation. Our trainees said, this amount of data collection is going to be really challenging since we don't have an electronic health record. Can you help us come up with a sampling strategy? So we gave them a training in judgment sampling techniques. Second, they said, we're physicians, we don't have a lot of experience in leading projects and planning projects. Can you give us some support on that? So we offered them a module on basic leadership skills for physicians. And lastly, they said, we don't have a lot of experience even in working with Microsoft Excel. Can you teach us some of the basics? So we gave them a module on data entry and data analysis to give them what they needed. The training program appeared to be pretty effective. We offered a 36-point multiple choice exam before and after the training and demonstrated an improvement in test scores from 47% to 80%. We also administered surveys before and after the training and found there was a large magnitude improvement in perceived QI skills after the training, and buy-in for quality improvement among our trainees was quite high. Perhaps more important than the training outcome are the clinical outcomes. Each of our trainees spearheaded a quality improvement project. They looked at non-neonatal mortality, length of stay for malnourished children, missing data, perinatal asphyxia associated mortality, and neonatal hypothermia. We're extremely proud of the impact all of these projects had and the work that the residents spearheaded, but I wanted to highlight 3 of these projects in particular just to demonstrate how incredibly creative the Ethiopian staff was. Dr. Ngusi's QI team was interested in reducing missing data in the registration books. To do this, his team recognized that interns who historically were responsible for documentation really had no incentive to document appropriately. However, our residents were responsible for compiling performance data for morbidity and mortality conferences. Recognizing that difference in accountability, he simply task shifted responsibility for documentation from interns to the residents. And in doing that, dropped missing data from 29% to 15%, meeting the Ethiopian national target. Dr. Abiye's QI team was interested in reducing length of stay among severely malnourished children on our malnutrition ward. To do this, he interviewed regional feeding centers. These are nutritional rehabilitation centers in patient communities that are charged with the task of getting malnourished children back on track after hospital discharge. He asked these centers what information they needed to take great care of their patients. He then created a discharge checklist for interns that systematically addressed everything the regional feeding centers expressed they needed and gave that to the patient to present to the regional feeding center at the time of discharge. Allowing them to do this, doing this allowed them to discharge patients much earlier in the course of nutritional rehabilitation to continue rehabilitation in their home community. And they managed to drop length of stay from 18 days on average down to 14. Lastly, Dr. Abdul Kadir was interested in continuing our mortality reduction project for non-neonatal pediatric inpatients. To do this, he established an externship training program with the flagship hospital in Ethiopia, Black Lion Hospital in Addis Ababa. Our residents in Gondar traveled to Addis Ababa and got special training in pediatric intensive care, and then brought what they learned back to our faculty and taught us how to get better in our setup. Ultimately, you reduced our mortality down to 3%. As far as we can tell, the lowest reported mortality in Africa from this cohort. We think that this site-level approach to quality improvement and patient safety may address a bottleneck, maybe the most important bottleneck in the world's QI implementation system. If we can unlock this bottleneck and engage providers on the ground to use the resources that are now getting delivered, we think we can see a huge improvement in patient care and in patient outcomes in the long haul. In 2012, I returned to the United States and had the good fortune to meet up with Alon, Unger, and Sujatha Sankaran. Drawing from their own lived experiences, these two had developed very similar conclusions to those that I developed. And it was so nice to plug into a like-minded community of people interested in quality improvement in low and middle income countries. They had been working on developing a quality improvement and patient safety training program at UCSF. And I'd like to hand the baton over at this point to Alon, who hopefully will give us a good overview of where we're at and where we've been with this program. It's been a pleasure working with him. Alon, do you want me to navigate the slides for you?
Do you mind?
Of course.
Am I able to? I think I'm co-host, so I wonder if
why don't I navigate for you?
let you do
You would
it.
have to stop share, then reshare on your screen. Yeah.
No, I'll live in luxury. I'll let David do it for me. So hi everybody, and thanks Dave for the handoff. I found that program really inspiring. Just from the beginning to assessing the data to the thinking through the interventions, the way that you worked with the teams and the way that you presented that and the impact. Can I ask you a question? I have a question about your presentation, which I think is helpful for us, which is, have you had any word or any follow-up about how these numbers have done after 2014?
For 1 year, from the mortality reduction project, 1 year of that data follow-up that I presented was from after all the expatriates had left the site. I know that subsequently, Ethiopia has had quite a robust national level quality improvement training program that may have supplanted some of the approach and technique that our trainees were using. But I know that mortality continues to be followed, that the morbidity and mortality conference system is still in place, but I don't know exactly what the mortality rate is at this time. It's a great question about sustainability alone.
Yeah, hopefully we'll set some time aside at the very end for everyone to ask some questions, because that material that you showed was very rich. So thanks for the handoff. I think that Dave and I and anyone really who has worked in these settings has found a lot of frustrations in terms of thinking about, well, how do we change the setting? And while there are lots of programs, Dave, if you don't mind going to the next slide, we struggle with the idea, well, they seem to be pretty disparate. They seem to be separated into either specialties, or they were curricula that were applied from the Western context or a more resource-rich setting. So initially, we did some literature search before beginning this project, looking at what kind of programs around quality improvement existed, where were they housed, and who provided them, and what was the material, what was the content of the material. And what we found was that the training programs and the learning in quality improvement had two sort of distinct elements. First of all, they tended to be siloed or isolated to vertical programs or disease-specific approaches, or hospital-specific approaches. So there was quite a bit of QI work and quality assurance work being done in the HIV field and malaria and TB, but not as much being done across the health system. Or there were programs a little bit like Dave's that were very specific to one particular hospital, which were very resource intense, having a Westerner or someone who is dedicated to the program both develop and implement the program. So we found them to be quite isolated. And the second thing, when we did a systematic review of the different curricula that existed for learners in low and middle income countries, we found that much of the material was adapted from the Western context. The principles of quality, safety, efficiency, patient-centered care, etc., were all the same, but the material that for the learners was used examples and concepts that were very specific to the Western context or resource-rich settings. So there wasn't a lot of curricula that were specific to the global health context, and that were difficult to apply to their setting. So we started to think about how we might create a curriculum ourselves to try and help learners, our learners from UCSF who are going abroad, but also to help our colleagues and collaborators in the field about how to develop these kind of skills, these core skills and tools to work in the field of QI, with the hope of ultimately improving the quality at different sites. So I'll say that we kind of developed these vision statements, which was initially that we thought that high quality, equitable, safe care was, and compassionately delivered, was achievable in low and middle income countries. And we started to think about how we could try and fill that gap. Our mission was to develop a program to increase the leadership capacity of our colleagues working in the field, to work in the space of quality improvement, to provide them with the education and the support, mentorship, to become local leaders. So those were sort of the beginnings of the vision for the program. We thought, well, how could we do it differently from what already exists? And the things that we wanted to focus on was, we really wanted to focus on the concept of equity, which was not always manifest in a lot of the curricula from the Western or the resource-rich perspective. We wanted to make sure that the program was collaborative, a lot like Dave's was, in the sense of using local champions, getting buy-in, and really building capacity. We wanted to make sure that we emphasized local knowledge and experience, local leadership, and that we were really sensitive to the global health context, that we were sensitive to the cultural context, to the interference, if you will, from the early slide that Dave presented, from both the policy and from the clinician. And that the problems that and the cases that we presented were really sensitive to the kinds of problems and cases that people encountered in these settings. We also wanted to make sure that it was experiential, because quality improvement is very difficult to teach in a textbook. It's really something that has to be encountered and practiced and reiterated, just as Dave showed you in the PDSA cycle. And lastly, we wanted it to be really patient-centered. We wanted to think about what is the context in which people practice, what is the experience of the patient and their families, which is very different than we have at UCSF, for instance, and what was the context and experience of the providers, not just the clinicians, the doctors, but also the nurses and all the other staff that were part of the medical team. Dave, if you don't mind going to the next slide. So we wanted to create kind of a two-part program. First part was to develop a curriculum that would be housed online, that would try and embody the different values that I just explained, and that people would have asynchronous access to. So people could access the online program at their own pace and work through the material, really work through the core concepts to provide them with tools and a way to develop their own sort of QI initiative. The second part of the program, which we'd hope to develop after the curriculum, is a coaching program. So in addition to providing the curriculum, to really provide one-on-one support for people who are working through their own QI projects in the field. But for now, I'll just focus on the curriculum. So the curriculum has, at the moment, 8 modules. The early parts of the modules are really to establish that foundational knowledge and the principles of QI. So the first and second modules are really on the importance of QI and really the basic principles of QI. And then we work through concepts and cases in safety. We talk a little bit about creating value. And that in the context of a low and middle income country is very different than we might explain value at UCSF, for instance. And then we really wanted to focus on equity and patient-centered care, which is a difficult topic. And then the last 3 modules, we were hoping that this would be a way for the learner to develop their own QI project. So how to build culture change, how to recruit and support stakeholders, how to work on concepts of sustainability, and then how the learner might implement their own vision for QI. So that was the overall view of the curriculum. If you don't mind going to the next slide. So we built the curriculum. We have a nice draft of the curriculum, and we wanted to make sure that we were kind of doing what we said we were going to do in terms of making sure that it was collaborative, focused on equity, patient-centered, and really sensitive to the low and middle income context, the cases that they see, the resources that are available, and all of the challenges that they face. So we created a survey and reviewed the first 2 modules of the curriculum with a number of our colleagues who were in low and middle income contexts, countries, or settings. And we asked them some simple questions about, well, how relevant did you find the curriculum to be to your setting? How useful and effective did you find the material? How practical in terms of initiating some of the concepts that we had suggested? How people or patient-centered it was? And would they recommend it to their colleagues as a useful program? And this was done by one of our UCSF HEAL fellows who works in Rwanda, but delivered the curriculum pretty widely. And it's a very small N size, but for the most part, people found it to be of use and hopefully effective. Next slide, please. But the free text responses show that there are lots of places that we can improve. And I think that you guys have identified a lot of those things in the earliest slide that Dave provided, where we're talking about what are our frustrations, what are our challenges. The first one was relevance. We thought that it's very difficult to create a curriculum that sort of applies to all people who are working in different contexts, some of whom were clinicians, some of whom, were nurses, some of whom were pharmacists, and other members of the healthcare team. So it's hard to make the curriculum relevant to different levels of training and levels of experience and practice roles. Second is usability. The modules were challenging. They were a bit long for folks, and it becomes challenging to do, especially if it's in an online format. So those are things that we need to think through about how to format and produce the modules. Practicality addresses the question of internet connection. A recommendation, it was challenging to deploy, obviously, the curriculum in places where English was not the first language or there was limited English proficiency. So many suggested translating the curriculum into other languages and also creating cases that were specific to the local context. Next slide, please. There was a second, we did a more focused review of the curriculum before producing the rest of the curriculum. And this was done by Ariana Safi, who is one of the master's students in global health, who did her capstone project. And she did structured interviews with 10 respondents, again, at different sites in low and middle income countries, where she had a pretty prolonged interview and asked them about, after they had spent some time reviewing the curriculum, they asked them about the strengths and the weaknesses of the curriculum. The strengths were, again, that it was clear, systematic, and readable. But the weaknesses were that they had asked that we tailor the relevance to the learner, since there's a great variability in learner and context. That they had asked us to show the benefits of the program earlier in the curriculum. And how do we think about how to optimize it for people who are quite busy? One of the challenges in QI is that everyone is very much overworked. So thinking about how to fit QI learning and fit QI work into a busy clinic or hospital schedule. Next slide, please. So we hope to adapt this material to, to address the concerns of the people that that had participated in the 2 parts of the studies. And so we're thinking about relevance and how to track it, how to make the content specific. We've been meeting with folks in other specialties about how to create different case tracks. So for instance, if we were going to deploy this to a program that is working in global health surgery, what cases and examples should we provide for a practitioner surgery in a low and middle income country? So we have been working with physicians from the American College of Surgeons about how to create a different track for surgeons. The same is true for pediatrics, OB, anesthesia, etc. We've been talking a little bit about usability and how to adapt it, how to make it more abridged, how to make the modules more appropriate and more palatable, and how to adjust the format and the examples themselves. Practicality is really interesting because it's not something that I generally have thought about very much, but thinking about how do we provide the curriculum online? Should we provide it in a format that is PDF or PowerPoint in addition to the online? How do we make it downloadable for people who have very limited internet connectivity? And how do we assess those things after the curriculum is deployed? And then the last bit, which is other, is continuing to think about how do we supplement the curriculum with another program, a wraparound program that involves mentorship and coaching. And what will be the incentives? What will folks want in order to participate in the program? Next slide. So just to go back to where we are, we started building the program, looking for funding in 2017, 2018. We've been developing the content in 2019 and 2020. Things have been a bit delayed because of COVID, obviously. And now we've done some piloting of the modules. The next step is really to revise the curriculum, and we have funding now to produce the modules into online format. In the meantime, we're also piloting some of the content from the modules with partners in health in Rwanda, the University of Global Health Equity. They have a program where trainees will come for a social medicine course every 2 weeks. And we're developing a 4-hour course for those students that we can teach, and also we use it to pilot the work and get feedback and assess our work. Hopefully we'll be able to deploy the modules within the beginning of next year, and then we'll be able to study really how they work, if they're effective, if they're helpful to the practitioner, to the learner, if they're sustainable. So if anybody's interested, feel free to reach out to us. There's a lot of work to be done. Next slide. I think that was highlighting just where we were. So lessons learned, international efforts to strengthen health systems find it hard to engage healthcare providers, and that there are many quality gaps. The other thing, thank you. The other thing I'll add to that point number one, which I did mention and I meant to mention earlier, is that a lot of the medical training, a lot of the training in low and middle income countries tends to focus on Western curricula. But there's very little by way of formal education and quality improvement, unlike we have at UCSF, for instance. The second point is quality improvement is possible in low and middle income countries. And we think that an effective complement to a lot of the top-down vertical programs is a bottom-up approach, a site-specific approach, just as Dave had pointed out in his last slide. And that there's a lot of work to be done, both in terms of the assessment of the curricula and the interventions, whether or not it's cost-effective to determine the value of quality improvement relative to other health sector investments across the health system. So that's the end of my portion. Dave, I think this would be a great time to open it up to everybody who's been patiently listening. And it would be great to hear some of your questions and think through some of these challenging issues with you all.
Thank you, everyone, and thanks, Alon. Does anybody have any questions, or does anybody feel comfortable sharing their experience with quality improvement and patient safety?
Hey, this is Zach. I'm actually dropping in from over on the Stanford side. I apologize if there's some background noise. I'm dialing in from the unit today, but I'm one of the ICU fellows over here. But this was really great. I don't have quite as much experience in quality improvement. My background was I spent some time in Malawi in residency and fellowship, and I'm working in Tanzania now. But our experience in Malawi, I think, was kind of reflective of what you guys have discussed. A lot of providers could come in and try and initiate quality improvement projects in the wards. But we really didn't have much success until we kind of hosted quality improvement training programs for the local providers, and people were really able to try and identify their own issues and their own solutions for the folks that actually worked in the unit and were there all the time. And I think they've had more success with it since then. But it was also really great, Dr. Unger, to hear about the modules that you guys are working on. We're working on some similar things over here. And it was really great to hear how you guys have been working through your thought process and your approach for your educational modules. So that was really great.
Thanks, Zach. No, your comment really resonates with my experience, Zach. After the experience we had in Ethiopia, where the residents really took this and took charge and continued developing projects, that was a site where I had worked in the site for more than a year and had drank a lot of coffee with providers and built a lot of trust. The organization I was working with asked me to try replicating this in Swaziland in a completely different clinic. And I found myself in a completely different role where I was that provider who airdropped in out of nowhere with this curriculum and was asked to put it on. And as you would expect, the uptake was much lower. The training program didn't land nearly as strongly. And the consequent projects were not quite as well developed. And the quality program there didn't really take off. I think that notion of having some kind of trusted insider really taking the helm, or if there's a training program where you can build local capacity and you have a group of people that are passionate about it, I really do agree with you that that's likely going to be a huge cornerstone of success to QI and resource limited settings.
Yeah, we had kind of a similar experience. It was really interesting for me, more so from an implementation science perspective. In Malawi, as some of you might know, bubble CPAP is a fairly ubiquitous technology that's been, I was in Lilongwe and we used it for everybody. And it was super interesting in fellowship to transition to being up in Tanzania. And the hospital where we're working, the staff there are very hesitant to utilize bubble CPAP. And we actually had folks from hospitals in Lilongwe and Malawi come up to try and advocate for introduction of that technology. But yeah, it was a new thing with outside people coming in, and we've been very, very slow to adapt bubble CPAP there. But that's more from an implementation science perspective than QI necessarily. But yeah, a very similar experience.
Interesting. Alon, I don't know if you'd feel comfortable sharing your email address, but I might put my email address in the chat. If anybody has questions after the fact or is interested in these programs, please don't hesitate to reach out. I'd be happy to discuss further.
Yeah, happy to. I wonder if it's, I know this is a question answer, but I have a lot of questions. I was wondering if I could reach out to one of the participants and ask Meron specifically, just Meron, you had mentioned early on that you had worked in labor and delivery interventions. I think it was in Kenya. Would you mind telling us a little bit about your experience?
Yeah, so I actually worked in Ethiopia as well during medical school, and we did a project on cancer patients and seeing what was like obstacles to care. So it was interesting to see like some of the perceptions that we thought were obstacles to care and things that we hadn't even thought about as far as like different stigmas to getting care. So I think a big learning lesson in that research project was, you have your assumptions coming in, but like really 90% of what you gain from it is going to be what you learn on the ground there, and like communicating with local like partners early on. One question I did have for you guys too was, in the setting where like something like that in Gondar was so successful, would it be useful to use those like local champions to take with you when you're promoting projects like this, in like another region, just because then they could kind of testify to like the success of it?
Ron, you're really speaking my language, and I feel like I have a like-minded colleague in you. Dr. Moretti, who was kind of my partner on all this, he and I had identified 2 other teaching hospitals at Mekelle University and Baradar University, who were very excited about recapitulating our training program. And then kind of some politics got in the way, unfortunately. We were asked to come to Ethiopia to bolster medical education, not to improve quality of care. And we tried to solve the medical education program by starting a residency training program. Our graduates replaced the expatriates on faculty, and we, the expatriates, worked ourselves out of a job, and we no longer had any legitimacy in Ethiopia. So there wasn't any money or resource to commit to scaling up. But Moretti was excited about it. He just didn't end up getting the resources he needed to promote the program in those 2 sites. You're identifying exactly the strategy we were hoping to leverage. I wasn't going to be involved, and I was just going to help mobilize resources, and Moretti was going to proceed to try and scale, if possible, at the other sites. I think that strategy would probably be very effective. These were training sites just like ours in very similar settings. I think the likelihood of success would have been much higher there than what we ended up doing in Swaziland, unfortunately.
Thank you.
Of course, great suggestion.
I think a lot of the comments from Zach and Maron and our own experience really suggest the importance of having local champions, of having institutional investment in QI. It's very, the curriculum hopefully will fill in a gap, but it will be very difficult to work in the space of QI and to make this work sustainable without people who are on the ground who are really invested, not just the practitioner, but at higher levels within the institution. And as you guys all know, there's so many different forces that are driving the priorities in any particular setting, and it's very difficult to generalize, but definitely having those local champions makes a big difference. I think the second point that Zach makes me think about again is the importance of having an opportunity to participate in QI and to really have a longitudinal experience that is supported. It's very difficult, as you've all mentioned, to drop in, provide a curriculum or an intervention, and then to leave. I think that the more sustainability we can show and the more kind of interventions over time, the more likely it will be that QI will stick. And then the last thing that I was going to say is we've been sort of toying with this idea of creating regional centers of excellence, so that there is one place who has really developed an expertise in quality improvement principles and practice that can serve as a resource locally, rather than having to replicate the same program over and over again. But really, our goal was, as I mentioned in our early discussion of our mission and our vision, was to really build capacity so that the QI principles are there, and so there are local experts that can really help folks work through the sort of continuous nature of QI practice.
Hello, can I ask a question?
Yeah, go ahead.
Please, my name is Garwick. I'm working with Lara Global Health. So we are a company who makes quite a few solutions that are often used in QI initiatives, I guess. Like it could be simulators, skill trainers, also more programs. Like we help support development of programs linked to more specific topics like newborn resuscitation or bleeding after birth, for very much linked to day of birth. And what I see is that in many of these implementations, there is an attempt to kind of add a QI element to these topic-specific programs. But then that component could be, I wonder if it's too small at times. So it's kind of an, I guess I'm curious on your experience on what it takes to get the first entry point to get started with QI, like whether that, like how much does it take? You had 8 modules. How long time do you normally plan to get to the first step if you want to get people involved and able to develop from a starting point? Thanks.
Maybe I can speak from my experience in Ethiopia, and then Alon, maybe you'd have a chance to address this more specifically from the curricular standpoint and what you might anticipate. Tor, I think we were a little bit lucky in some ways in Ethiopia in that our first try at this was a resounding success, and we saw the data change almost immediately with our round of interventions. In the literature I've been exposed to, a major element to creating a sustainable QI program is a spectacular early success. And if you can't have a spectacular early success, any early success is good enough. But the notion that you've tried something and it's failed can be pretty demoralizing. So many people in quality improvement, when building a program at a site, will recommend start off with something that you're pretty darn sure you can achieve, and just to get people to bite. And then you can reel them in by inviting them to identify other potential targets once that initial excitement is generated. In those sites, like in Swaziland, for example, where we didn't have a single initial project that was successful, it was just, we literally sunk our own ship and it just didn't go anywhere. And that I'd encourage against. Trying to find something that you can really solve and that you have control over would likely generate that early nidus for success.
Tor, I haven't seen literature that suggests how long it takes for somebody to become a QI expert, but I've had a lot of discussions with people who are working with this on the ground and my own experience, and I think that the answer is it's very difficult to teach in a 2-hour session or even a 2-day session. The places I've seen it best is where there are often 2-day sessions, but it oftentimes leads to people who want to develop a particular focus in QI, and there's usually a longitudinal program lasting a year, but with continuous coaching and mentorship. I think that piece is really important, as well as the local buy-in. The other part, which I think is become obvious to me, is that the teaching of the principles of QI and thinking about it's a different approach to problems, of medical problems, than we typically learn in medical school, and that approach of QI is not typically taught in the medical education for practitioners in low and middle income countries. I'm generalizing here. It's become more popular and there's become more involvement in the curriculum, but it is not as a big a part of the curriculum. And so I think personally, without any evidence to prove it, that starting early is when people are in their training and teaching the principles of QI is really important to getting them to buy in and think about it as a process for continuous improvement, even after they specialize into different areas of clinical practice.
I want to thank everyone for joining this session, especially David and Alon. This has been a wonderful presentation. I've learned a lot. This is definitely not my area, and I feel like I'm inspired to go do great work seeing what you've been able to accomplish. So thank you everyone for joining the session. I just would like to say again, I'm putting in the chat if you can take literally a minute to complete the short session evaluation. We really do appreciate your feedback, and as do the speakers. And there's literally 2 questions. So with that, I just want to say thanks to everyone. Have a great rest of your week. and hope to see you with the future sessions.